I'd like at first to thank all the previous colleagues who presented their fantastic works. Thank you for the effort and thank you for the useful information. I'll try to summarize our work in a few minutes, inshallah. I am Emad Magdy, a lecturer of nephrology in Mansoura University, and here is our work regarding the evaluation of regulatory T cells in SARS-CoV-2 infected hemodialysis patients, clinical and radiological correlations. Regarding the background, the regulatory T cells in COVID-19, regulatory T cells are an important subpopulation of T cells that exert immune suppressive effects. Tregs is significantly reduced in COV patients, and this reduction may affect COVID-19 patient on several aspects, such as weakening of the effect of the inflammatory inhibition, causing an imbalance in the immune cells, and increasing the risk of respiratory failure. To this point, there's an implication for this. There is an emerging concept of Treg targeted therapies, including post-adoptive Treg transfer and low dose of interleukin-2 treatment, and the potential Treg boosting effect of therapeutic agents used in treatment of COVID-19, including dexamethasone, vitamin D, tocilizumab and sarilumab, chloroquine, hydroxychloroquine. All these are sidely affect the Treg activity. But in hemodialysis patients, there is no data on the T cell response to SARS-CoV-2 in hemodialysis patients currently available. We all know that the accumulation of uremic toxins was reported to be related to the impaired or dysregulated immune response, both in innate and adaptive immunity. And as we show, the immune response in CKD and uremia can be activated abnormally or inactivated abnormally, the cardiovascular disorder, the inflammation. So we have multiple players, and we don't know the exact relationship between the activity of the Tregs and the outcome. In the era of COVID-19, hemodialysis patients exhibit a greater risk of infection, but we have some suggestions that the extracorporeal therapies have been studied as a potential treatments for the removal of cytokines in critically ill patients with COVID. And those were one of the published studies that the continuous renal replacement therapy with the addition of a cytosorb cartridge in critically ill patients with COVID-19 plus acute kidney injury, this was a case series predicting that. So Tregs have been found to be remarkably decreased in hemodialysis patients before the pandemic of COVID-19. So now we have an evidence that the Tregs is reduced in the COVID-19, and we have an evidence that the Tregs is reduced in the hemodialysis patients, but before the COVID-19 pandemic. So our name now is clear. Our aim was to characterize the Treg expression patterns in COVID hemodialysis patients, not in acute kidney injury, but on the regular chronic kidney disease patient or end-stage renal disease patient on hemodialysis for more than 6 months, and its relation to the clinical and radiological severity. Our study population was that simple. Please, I ask you to make a clear notice about the photos, because we will use the photos in the results. So we have 3 groups, group of COVID-19 infected hemodialysis patients, chronic hemodialysis patients, not acute, a group of COVID only, not hemodialysis patients, and a control group of hemodialysis patients non-infected with COVID. The reported or the data of interest will be the clinical data, radiological data, and the bloods. The important clinical data: oxygen saturation at admission, duration of hospital stay, in hospital mortality, the patient stay in hospital in outpatient clinic, ward, or ICU, and the patient comorbidities. The radiological data: the CURAD score, the total severity score in CT, the percentage of ground glass appearance, and the bloods, differential leukocytic count, neutrophil to lymphocyte ratio, the dimer test, and the flow cytometry analysis. Our strength points is the new suggestion and analysis of the CT score and the flow cytometry analysis. How we made it? We have two separate consultants of radiology in our team, judging the total severity score in the CT. 5 lobes of the lung were assessed for ground glass opacities, mixed ground glass opacities, or consolidation. Each lobe given a score of 0 to 4, and the total score more than 7.5 is considered severe affection. The flow cytometric analysis, we characterize the Treg by characterizing getting through the CD45 for the T lymphocytes, and then CD4 for the T helper, CD425 FOXP3 intracellular for the characterization of Treg, and another marker of Treg activity, which is CD39 on the Treg, is assessed. Our main results, I will divide the main results in four sectors. Number one, the comparison between all COV patients, whatever, on dialysis or not. So all COV patients in one socket and compared to the control of the hemodialysis patients, 60 over in comparison to 40. Those were the results. There is significant lower total white blood cell count, neutrophil, lymphocytic count, and CD4 positive T cells and Tregs in the COV-infected patients, whatever they are on dialysis or not. And the hemodialysis patients have higher percentages, and as we see, a high level of significance. Then we pass to comparing the COV hemodialysis patients versus the COV patients. The COV and the COV hemodialysis patients are comparable, that they all have a reduced total white blood cells, neutrophil, lymphocyte, and CD4 cells and T regulatory cells. Also, they have a comparable clinical presentations, comparable total severity score in the CT, comparable ground glass percentages, comparable age and comorbidities, especially the diabetes. The only difference was in D-dimer. The D-dimer in COV hemodialysis patients was much more higher than the COV patients. So conclusion number one, the presented study showed significantly decreased CD4 and Treg cells in patients with COVID-19, whether maintained on hemodialysis or not, and this suggests that these observed alteration results from a SARS-CoV effect rather than a hemodialysis effect. Despite the comparable clinical and radiological severity, there were different outcomes in the COV hemodialysis patients. So in COV and COV hemodialysis, the admission to ICU was significantly less in the COV hemodialysis patients. The hospital stay, the hypoxemia, and the mortality were significantly less in the COV hemodialysis patients, which contradict the known information about the severity of COVID in our patient. This contradiction can be attributed to the more frequent cytokine clearance in regular hemodialysis session, or the immune dysregulation and the premature aging of T cells in the uremic patients, and lessened severity indices for patients included in the COV HD group that not met statistical significance in the study sample size. The correlations. We correlated the expression of CD4 cells and Treg cells with the clinical severity criteria and the radiological severity criteria, and we found that in COV group of patients, only the CD4 is correlated to the number of days of admission in the hospital and of the total severity score and for the mortality. And this don't applicate in the COV hemodialysis patients. In COV hemodialysis patients, the most important marker was the neutrophil lymphocyte ratio, which is higher and related to the number of days of hospitalization, the oxygen saturation, the total severity score, and the mortality. So conclusion number three, CD4 cells counts are negatively correlated with clinical severity. Neutrophil lymphocytic ratio is strongly correlated with clinical severity in COV hemodialysis, and Treg cell counts are not correlated to any radiological or clinical severity parameters. Our study is the first to evaluate the effect of hemodialysis in T regulatory cells. We provide an evidence that T cells, particularly T regulatory cells, decline in hemodialysis patients with COVID-19 and suggest that hemodialysis per se doesn't distinctly impact the T cell response in patients with COVID-19. Therefore, the T cell target therapies for COVID in general population may be effectively used in hemodialysis patients. And this is the team members. We have all the Mansoura Faculty of Medicine staff members. Okay, in the nephrology, 1 minute please to acknowledge The great team, the nephrology, my colleague Dr. Rasha Samir, Dr. Tamer Gaber in microbiology, who helped us in the hypothesis, Dr. Ahmed Goma, Dr. Ragi Nader in the hematology unit, clinical pathology, Professor Nashwa Abu Samra, Professor Dua Shaheen, and the radiology, Dr. Dua Khadr, Dr. Hind Gamal, and then pulmonology, Dr. Marwa Omar. And at the end, I can't forget to thank our heroes in the isolation hospital. So we have Rabab, Shayma, Ala. Those are the heroes in the isolation. Yes, yes. Okay. Thank you. Thank you.
شكرا الحقيقه دكتور عماد على البرزنتيشن وعلى الشغل الحلو قوي قوي اللي معمول الحقيقه. وهي دي برضو حاجه مهمه قوي، الاميون ريسبونس البيشنت ويز هيموداياليسيس والسيتوكاينز كمان اللي موجوده عندهم. فهو دوت برضو مخلينا مش عارفين السيفيرتي معاهم اقل. علشان ايه؟ عشان الاميون سيستم بتاعهم مش شغال كويس. علشان
يعني احنا اندهشنا انه كسيفيرتي وايز السي تيز بتاعتهم فيها جراوند جلاس اوباستيز اب تو 50%. وكل اللاب بارامترز as severe as the COVID, but most of them are managed outpatiently. Just came to the isolation hospital to take the hemodialysis session. So the same radiological but different clinical.
اعتقد ده اللي موجود عندنا كلنا يعني. احنا مستغربين الناس. الحمد لله يعني.
Okay, thank you.
شكرا.
Thank you. Thank you.
ناو بقى ديسكشن. لو حد عايز يسال اي حد في السبيكر اللي اتكلموا معانا كلهم يتفضلوا معانا كده لو حد عايز يساله. دكتورة شيماء كان ليها شويه اسئله. شويه اسئله
نبدا الكومنتس. دكتوره مروه كمال from your study. هي دكتوره مروه كمال موجوده؟ Yes. دكتوره مروه, study is very well constructed as usual and as expected, but I want to ask you from your study when you will do this genetic test, especially nephrotic syndrome minimal lesion. We are knowing that it is responsive and also the resistance in these cases is very little. Also in FSGS we are starting steroid, and this message we can get it clinically very easy.
Yes.
When what the criteria of patient that you will select to do the genetic testing?
Yes, Dr. Many thanks for your excellent question, and it's actually the main point of our study. From our study, it's based mainly upon the experience of our study. It's better when a patient come, why even child or adult, and have no reason minimal change glomerulonephritis or focal segmental glomerulosclerosis after performing light examination, immunohistochemistry examination, and after exclude all other causes as I have mentioned. It's better to do a genetic course in order to avoid the long-term complication of the immunosuppressive, which will give no result at all, except such comorbidities such as diabetes or hypertension, femur head necrosis, complication of the prolonged use of steroids and other immunosuppressive.
I am with you that we are going to treat the idiopathic GN, not the secondary causes, and this is in the literature. But I ask about the patient. When the patient to ask to do this genetic test, especially are knowing this test is highly expensive. It is not easy to done. It is not available in labs. So which criteria of patient?
For any patient with idiopathic cause, minimal change or focal segmental glomerulosclerosis after exclusion of all secondary causes. لو في فلوس يعمل، لان ده هيوفر عليه كل الكومبليكيشن بتاعت عمالين نديله. ما احنا برضو لما بنديله سترويد واميونو سبريسيف بنديله بفلوس، لما بيجي له دايابيتس بيتعالج بفلوس.
I think it is better to be done for patients who have elevated serum creatinine, or patient take the first chance for steroid and not responding, but not to be the initial. Once I diagnose this patient, to refer him for genetic testing.
هو حضرتك هو السي تي فاريانت كان طالع في كل البيشنت الستيرويد ريزيستنت، انما كان في بيشنت من الستيرويد ريلابسر او فريكوينت ريلابسر كانوا برضو طالعين سي تي، وفي 5 بيشنت من ال100 بتوعنا بروجريس تو اند ستيج وما كانوش ستيرويد ريزيستنت، كانوا ريلابسر. كانوا ريلابسر. انا ما حطيتش كل الجداول عشان حفاظا على الوقت، انما في بيشنت 5 وصلوا ان هم بقوا اند ستيج رينال ديزيز، وفي بيشنت تانيين دخلوا في كومبليكيشن وكانوا ريلابسر، ما كانوش ستيرويد ريزيستنت من البدايه. انا دي يمكن بوينت بس ما وضحتهاش. بس
point which is valuable that it
Yes.
also to be done in the relapser not only in the resistant one.
and yes كان في ناس سي تي heterozygous in the relapser especially the frequent relapser. فعشان كده it's better والله لو في الامكانيه الماديه ان احنا نعملها لكل البيشنت. شكرا للسؤال حضرتك يا فندم. شكرا.
دكتور احمد لو متواجد. احمد يحيى. Thanks for your presentation for assessment of the cluster of differentiation as regard regulatory T cell and all the therapies at time being going to give Treg IV in order to reduce the immune suppressive in transplant recipients at the end of the first year. But from your study, you said that you found that patient with measuring the T regulatory cell, you found that always who entering in rejection, they have also only elevated CD8, but down regulation, the patient who not rejected, who having down regulation of CD8 and up regulation in CD4 cells.
Yeah.
What is your explanation?
Okay. In the rejection group,
As regard to rejection,
Okay.
This is the golden point from your
Okay.
study, that we are measuring the T regulatory cell in the patient who are on low steroid or steroid free in order to minimize our immune suppression.
yeah.
So when we are measuring this cell, if I found it in my target points and I have a high expression of other clusters like CD4, this is not makes me annoyed, so I will continue my withdrawal of steroids or to maintain the patient as the same.
Yeah.
Okay, and the major marker that you are said that CD8,
And
CD8
CD4.
should be suppressed in order to make sure this patient
Yes.
will not enter in further rejection. I get it from the study, if I am right.
In our study, it was just a marker. CD8 is a marker for rejection. Actually, the weak point in our study that we didn't perform this analysis during rejection episodes. No, we retrospectively recruited the patient, not at the time of rejection, and it may be a weak point, and we didn't evaluate this point exactly. But among the rejection group, we found that CD8 was higher, and it was associated with lower regulatory T cells. Lower rates of expression of regulatory T cells, and that's the mechanism of action, by the way, of regulatory T cells. Down regulate, its main action is to down regulate CD8. CD8 is known to have its cytotoxic effect. Yes, okay. Its effect on cytotoxic T cells. The another point is that CD4 positive cells was high among rejection and non-rejection group. This because we didn't assess the type of T helper cell. As you know that T helper 1 and T helper 2 and T helper 17 each one have a different effect on the graft, and we didn't perform analysis for this point due to cost limitations, by the way. But if we, I think if we did this analysis, we will get point why CD4 was high in no rejection group and in steroid-free and steroid-based group.
Second Q for you also. Did you mention the timing between the post group who is more than 1 year of transplant and who is less than 1 year of transplant? As you know, after
5
1
years.
year of transplant, there is a tolerance started to be present, especially other immune cells like exhausted T cells, which is responsible for tolerance in many patients.
Yes, it's 5 years. 5 years after transplantation. It was about long-term evaluation.
All the patient after 5 years
Yeah,
post-renal
yeah.
transplant?
Yes, 5 years.
Okay.
Okay, thank you. Thank you.
دكتور محمد عصمت مش موجود.
دكتور محمد عصمت لو متواجد. طيب كان في دكتورة غادة. Thanks for your excellent presentation. You are talking about the NIGAL is a predictor of lupus nephritis, but at this point not a predictor of lupus nephritis, rather than it is a marker of acute kidney injury and follow-up. It is not specific at all for lupus per se. Even you are found a correlation between the activity index or T3. What I want to ask about, how did you do any follow-up periods for NGAL, and what is the washout period for another relapse in these patients?
هو الاستادي الحقيقه احنا بدانا يعني كانت في خلال فتره الاندكشن بس، فاحنا اشتغلنا على الاندكشن، يعني العيانين اللي هم اخذوا اندكشن اشتغلنا وشفنا الانجال، لكن فولو اب للانجال ما عملناهوش. هي كانت يعني استادي ان احنا بنشوف يعني الريسبونس تو تريتمنت، يعني هل انا اللي عند الكات اوف بوينت بتاعتي دي، يعني عند البيز لاين دي اللي هي الكات اوف بوينت بتاعتي، ان العيان ده هبريدكت ان هو ريسبوندر ولا نون ريسبوندر عن طريق الانجال. لكن هو طبعا مش سبيسيفيك بس لللوبس، احنا استخدمناه كماركر للاكيوت كدني انجري.
الوش اوت بيريود بتاعتنا تقريبا قد ايه؟ يعني انا النهارده، لان انا مثلا ممكن الانجال انا استخدمه ايرلي ماركر فور اكيوت كيدني انجري عادي زي ما بستخدمه في الاي كي اي، ولكن في عيانين لما بتبقى اندوبس اكتيفيتي بس الديفر بالنسبه لي لو هو مثلا ستيل هافينج اكتيفيتي فور هاو ماني مانثس، how many time it would be needed to wash out its high level in order to depend upon it in the patient with activity.
I think ان هي
another episode.
يعني I think ان انا يعني ان انا هعمل ده في يعني المفروض ان انا هعمل ده، انا عملت في فتره الاندكشن بس هل ان انا هعمل لبعد يعني في الفتره بتاعه التريتمنت دي؟ يعني انا مش فاهمه قصد حضرتك.
خالص اللي هي
لا انا عملت بيفور اندكشن، يعني العيان جالي وهو في اكتيفيتي، وبعدين during فتره الاندكشن.
Not about your study, from the literature. Wash out period to reach to normal level of NGAL, how much it take? It's half.
لا مش فاكره صح. لا
حضرتك عملتي مره واحده بس؟
عملت بيفور وافتر اندكشن،
وعملتي في المرتين الكورليشن مع الماركر بتاعت الاكتيفيتي. كان سيسين، كان بوزيتيف كورليشن.
It is excellent study.
Thank you.
Mentioned just thus we are asking about the T-hub for this marker in order that we are depending on it on relapses in another relapses or not.
هو الريكومنديشن هو محتاج ان الاستاد تبقى اطول شويه، اطول كمان من بعد فتره الاندكشن. ثانك يو.
دكتور احمد بقى، يعني كنت بس بسال حضرتك، عملت كورليشن مع الماركرز اللي كنت عاملها ديت مع الكلينيكال كورليشن، اي كارديوفاسكولار كومبليكيشن او اي حاجه تاني، ولا هي بس لابوراتوري؟ لابوراتوري. لا هو